to the choir most of the time here. But again, I had the opportunity to work with them with Fight Asthma Milwaukee Allies, specifically with the home visiting program. Got off on a late start, unfortunately, but there's always circumstances that are unforeseen in anything that we do. So I hope to continue working with FAM with their home visiting program and hopefully other endeavors in the future. So you guys know a little bit about me. Let me begin by kind of talking a little bit more about my background. Starting with my education, I got my undergraduate degree. First, I'm a Milwaukee native, born, raised in Milwaukee. Got my undergraduate degree at UW Oshkosh, Bachelor of Science, a major in biology, minor in chemistry. And then soon after my undergraduate degree, I decided to try and explore a career in public health and began my journey to obtain a master's in public health at the Medical College of Wisconsin. I then decided to take somewhat of a sabbatical to obtain my medical degree and did not anticipate how long it would take. So I attended the St. George's University School of Medicine in the Caribbean, enjoying weather much like what we've been experiencing over the last few days, except over a period of 2 years. I then returned to the Midwest and completed my clinical training in Detroit, Michigan. And then I returned to Wisconsin to complete my residency at Marshfield Clinic and Ministry, St. Joseph's Hospital in internal medicine. Last summer, I started a fellowship in pulmonary and critical care medicine here at the Medical College of Wisconsin, and boy, has it been a busy year. So during my time as a resident in my intern year, I decided to try to complete my my master's in public health, contacted the Medical College of Wisconsin, and here I am. Hopefully, I hope to complete the public health degree soon. So a little bit about my career goal. To bridge the gap between private and public health, achieving optimal health outcomes while at the same time reducing healthcare expenditure, I believe can be realized when healthcare and health insurance organizations team up with local, state, and federal public health departments. The program I participated in delivering is a fine example of how private and public health agencies can achieve this with asthma. As a resident, I participated in many quality improvement projects within the healthcare organization I worked. As a fellow, I'm currently involved in revising pulmonary procedural workflows. Quality improvement projects have the ability to help improve outcomes, improve client and employee satisfaction, and reduce expenditure. By improving health literacy through interventions that aim to educate and improve one's knowledge of their disease process, I believe empowers them to better manage ailment and reduce unnecessary or avoidable healthcare resource utilization. Improving the health literacy of a target population has the potential of improving the health and knowledge of others indirectly. A mother who is more knowledgeable in avoiding asthma triggers by recognizing early symptoms and administering treatment will better care for their child and better educate them similarly. I plan to focus my career pursuits on improving the health of people of all ages, genders, and races. I've had no previous public health field experience before this. The skills I believe I've shared with the program include my background in science, medicine, healthcare, prevention, and quality improvement. So I guess let's get down to it. What is asthma? Asthma is a long-term inflammatory disease of the lung airways, causing variable and recurring symptoms due to reversible airflow obstruction and bronchospasm. In layman's terms, it's when your breathing tubes become small, narrow, and as I tell the children in the program, full of boogers, making it difficult for you to breathe. Symptoms associated with asthma include cough, shortness of breath, wheeze, chest pain, and or fatigue. It is not curable, but it is controllable. Both males and females, children and adults are affected by the disease. Nearly 26 million Americans have asthma, including more than 7 million children. It causes millions of lost school and work days every year, and is the third leading cause of hospitalization among children. Asthma is one of the most common chronic disorders in children, affecting over 7 million children under 18 years of age. Asthma is the leading cause of limitations in daily activity, and costs our nation $56 billion in healthcare costs annually. An estimated 500,000 people in Wisconsin have asthma. That is 1 in 10 adults and 1 in 13 children are affected. In Wisconsin, there is 1 death every 5 days from asthma. Nationally, there is 9 deaths every day. It costs Wisconsinites $100 million annually. Locally, 1 in 10 Milwaukee residents have asthma, and in some public schools, 1 in 4 children have asthma. Milwaukee County has the highest rate of asthma hospitalizations and emergency department visits in the state. So clearly, asthma costs money and lives. But there's opportunity. There's opportunity to improve those statistics. In Wisconsin, among those with asthma, less than half of adults and children receive the recommended 2 checkups per year or receive an asthma action plan from a provider. Less than half of the adults under 50 receive the recommended flu vaccine. Although asthma cannot be cured, it can be controlled. Management includes avoiding triggers, recognizing symptoms, knowledge and administration of medications, following an individualized asthma action plan developed by a physician can help avoid preventable or unnecessary healthcare visits and save lives. Teaching people to manage asthma on their own plays a key role in controlling the disease. There is not enough time during a physician visit to deliver the needed education to optimize asthma outcomes. Physician visits therefore tend to be medication-centric, that is, ensuring patients are on the necessary medications and are taking them appropriately. But even this piece of education isn't always communicated effectively. The failure or shortcomings of the physician visit can be corrected within the community. Delivering education away from the doctor's office can help empower individuals to take control of their asthma. One way to deliver education is in the asthmatic's home. Home-based, multi-trigger, multi-component interventions with an environmental focus for persons with asthma aim to reduce exposure to multiple indoor asthma triggers, that is, allergens and irritants. These interventions involve home visits by trained personnel to conduct 2 or more activities. The Guide to Community Preventative Services, also known as the Community Guide, is a free resource to help public health officials choose programs and policies to improve health and prevent disease in their community. Systematic reviews are used to answer specific questions. These questions: 1, which program and policy interventions have been proven effective? 2, are there effective interventions that are right for one's community? 3, what might effective interventions cost, and what is the likely return on investment. The home visiting programs reviewed by the community guide focused on assessment of the home environment. Specifically, the focus is to change the indoor home environment to reduce exposure to asthma triggers by providing education about the home environment. Most programs also included one or more of the following activities: training and education to improve asthma self-management, general asthma education, social services and support, coordinated care for the asthma client. So what is the evidence for this intervention? Currently, the evidence is stronger for children than adults. This is probably due to the insufficient number of studies available that focus on this intervention in adults. The community guide reviewed 23 pediatric studies versus 3 adult studies. The studies in children supported a trend toward reduced asthma symptom days, days of school missed, acute healthcare visits, hospitalizations, emergency department visits, and unscheduled office visits. Overall, however, there was no significant improvement in pulmonary function. Yet again, asthma is not curable, but it is controllable. More studies are needed to look at the effectiveness of this intervention in adults. Our home visiting intervention consisted of a total of 6 one-hour visits. The first 3 visits focused on general education, while the final 3 visits focused on environmental assessments, of course with an educational spin. During our first visit, clients completed the IRB consent and an asthma education pre-test. The asthma pre- and post-test has multiple choice, true, false, yes, no questions. We then defined asthma and reviewed common medications, controller versus rescue medications and what are the differences, when to take which, and taught spacer use to optimize medication delivery. Clients were given spacers and taught how to clean and care for their spacer. Some clients already had spacers but lacked the knowledge on how to appropriately use and care for them. The second visit, clients were taught how to recognize signs and symptoms of asthma and common triggers. Clients were provided pillow covers to reduce dust mite exposure. The third visit, we discussed what an asthma care plan was. The clients I worked with did not have an asthma care plan provided to them by a physician. We also discussed techniques and how to monitor their symptoms to better recognize an impending asthma attack through the use of peak flow meters and recording the numbers from the peak flow meters along with their symptoms in an asthma diary. I was able to spare a few peak flow meters from work to provide families. The remainder of the visits focused on environmental assessments and green cleaning techniques. Families were provided recipes for green cleaning, that is chemical-free, all-natural cleaning products. Sample products were provided and preparation and use were demonstrated. We walked with clients through their home and helped identify potential asthma triggers. If significant household issues or exposures are identified, we try to help the client obtain the needed resources if possible. We then wrap up with a phone follow-up a few weeks after our last visit. The data we collected come from validated screening tools, such as the ACT or the asthma control test and the TRAC score. At each visit, we ask a number of questions on our asthma control summary form. For example, 6 separate questions. In the past week, 3 months, and since last visit, how many ER, urgent care, and unscheduled physician visits did you have for asthma? We asked about the number of hospital stays, steroid prescriptions, and number of days absent from school or work during the same time frames. We had questions inquiring about the use of asthma control or quick relief medications. And lastly, we can compare pre- and post-test results. I do not have any data to share with you today as this project is ongoing. So, I guess, let me discuss a few of my reflections. This project has definitely been an eye-opening experience. I worked with only a few families so far. They really enjoy visiting with my wife and I, discussing our asthma education, and they're always surprised at what we have to say. However, there's definitely have been some challenges and areas for improvement, as with every public health project. The biggest area for improvement, I think, is with my busy schedule as a fellow. I found it very hard. Some days I worked 80 hours a week to schedule a client visit. And I really enjoy the client visits, I really do. But I often had to reschedule the visits, or I showed up at a home and the client was not there and I had to wait. But when they did arrive, they were always interested in what I had to say. And it wasn't their fault. A lot of our clients didn't have their own transportation. So when they were able to get a ride to the pharmacy, the grocery store, they just had to take it. So sometimes there was a lot of cancellations at the last minute. Many of my clients, one specifically was very good at calling me, sometimes at the last minute or the night before, but she was a very good communicator and well organized, and I appreciated that. As with every public health project, funding is an issue. I know we could reach more families if we had the help to do so. I found it extremely difficult, again, to schedule and often reschedule visits during my busy schedule. In an ideal world, and Aaron and Mitch are probably going to laugh, in an ideal world, a full-time scheduler could schedule visits during same-day cancellations, minimizing the time spent by community educators in the field. My families often needed about 3 reminders after a visit was scheduled to ensure that we kept that visit. Lastly, I think it's challenging because much of our education was directed towards children, but however, adults also come with many IQs and many education levels. So I think it's challenging to deliver some of the education, or challenging to develop and deliver a curriculum for all learning levels. Moving forward, what's my plan? Well, I definitely continue to stay with FAM. I definitely continue to do these home visits in my free time. I would like to continue doing home visits with FAM and continue looking at the data that we collect for my capstone project, which I'm thinking about completing at the end of next spring now. I think we have to sit down, organize, and evaluate the data that we have collected so far with our home visiting team. And there's also a potential for bringing in environmental ambient air assessments into our home visit and giving our clients real-time feedback. So I'd like to give a special thanks to Aaron and Mitch. I know that I was only able to visit with a few families, but again, I'm hoping that I can continue to help out. And lastly, with Kim Cantardi, Medical College of Wisconsin, for their patience with the late acceptance of the IRB, and often my busy schedule as a fellow. Sometimes I'm not the best at getting back at emails. But again, so I apologize, but I thank you for your patience. And that's it. That's what I have for today.